Hi, Tony.
Doctors, we are live now. We can start the session.
Okay, we'll start, Tony. Thank you.
Do you want me to start? Okay, well, thank you. Thank you so much.
No, I'll just introduce everyone. I'll just welcome everyone. Fine. So, good evening, everyone. So, welcome to the VRSI Grand Rounds. Today, it's a little special for us, especially some of us who are very fond of inherited retinal dystrophy, and we are practicing it for quite a while. So, I would like to thank VRSI President Karobi Lairi ma'am and Dr. Mudit, Chairman Scientific Committee, and the entire MC members for this opportunity. So today we have many eminent vice counsel and discussants who will be throwing some more light into the uncharted territory of inherited retinal dystrophies. And it gives me an honor to invite Professor Anthony Robson from Moorfields, and he's someone who needs no introduction. So he's the go-to person when it comes to electrophysiology. Whenever we have any doubts, we keep troubling him, asking, and he's always kind enough to answer our queries. And he's been part of many webinars and also some of the physical meetings which are conducted here in India. Welcome, Professor Robson.
Thank you.
And we have Dr. Subhadra Jalali ma'am, Dr. Rajini ma'am, and Dr. Parveen Sen ma'am, who will be the vice counsel. And we have also have discussants, Dr. Deepika, Dr. Shrikanta Padi, and Dr. Brijesh Thakkar. So welcome you all. So first we'll start with Professor Robson's lectures on integrating genetics, imaging, and electrophysiology in inherited retinal diseases, followed by an interesting case discussions. Over to you, Professor Robson.
Thank you so much, and thank you for inviting me. It's an honor. It's an honor to contribute. So it's a large topic. I can't cover everything, obviously, but I'm going to show some selected clinical examples to try and illustrate the principle of integrating this sort of clinical and genetic information. First of all, just briefly, I want to describe the main electrophysiological methods. So today, I'm going to talk about the full field ERG, which is used to assess the function of the photoreceptors and bipolar cells. I'm going to talk about the pattern ERG that comes from the ganglion cells largely, but for practical purposes, you can use P50 in the pattern ERG to assess macular function, and you can also use something called a multifocal ERG to assess macular and posterior pole cone system function. And I'm going to touch upon the visual evoked potential as well, which is used to assess the integrity and function of the visual pathways. And just to highlight, we perform these tests according to published international standards. And this is the international standard dark adapted ERG series. And briefly, we can use the dim flash rod ERG to assess the rod bipolar cell function, although it depends on the rod photoreceptors. A strong flash ERG has an A wave that comes largely from the rod photoreceptors, a B wave largely from the bipolar cells. And after 10 minutes light adaptation, we can use the light adapted ERGs to assess generalized cone system function. Responses that come largely from the cone on and off bipolar cells. Now in children, we can shorten protocols and concentrate on responses that give us the most diagnostic information. So sometimes we do that here at Moorfields. We use skin electrodes and a shorter ERG protocol. And I want to mention that because I'm going to show an example in a few minutes' time. It's really important to remember, it's an important diagnostic principle in electrophysiology. The macula contributes minimally to the full field ERG. So cone density is greatest at the fovea, but it's important to remember the fovea is a tiny area compared with the retinal periphery. So, 200,000 cones in the fovea, 7 million cones in the periphery, and it's those 7 million cones that largely account for the light adapted full field ERG. By definition, in macular dystrophy, the full field ERGs are normal. So we need some other method of assessing macular function, and I've mentioned the pattern ERG, a response to an alternating checkerboard, and we can use P50 to assess macular function. And also the multifocal ERG, which has higher spatial resolution than the pattern ERG and can assess cone system function over a larger area. Okay, so some quick clinical examples. And I thought I would start off by looking at the commonest monogenic cause of macular or retinal dystrophy. In other words, Stargardt disease, ABCA4 retinopathy. It affects about 1 in 10,000. It's autosomal recessive. Patients typically present with central visual loss, and classically there's central atrophy surrounded by flecks. And occasionally, in young cases or in early disease, you can see subfoveal cavitation on OCT. Now, this patient has a large area of macular atrophy. They're 50 years old. The pattern ERG P50 component is undetectable. Compare that with this normal example. But the full field ERGs are normal. In other words, this is dysfunction confined to the macula. A much younger patient with Stargardt disease with milder fundus autofluorescence changes, there's macular dysfunction with generalized cone system involvement. Electrophysiologically, this is a cone dystrophy. And in a third patient, another teenager, macular dysfunction with generalized cone and rod system involvement. And the point is, you cannot predict the functional phenotype just by looking at the fundus autofluorescence or the posterior pole. Now, here in Moorfields in the department, we see hundreds of patients with Stargardt disease. We don't see them for diagnostic reasons. You don't need an ERG to diagnose Stargardt disease, but we do see them for prognostic reasons. There's good longitudinal evidence that if you have Stargardt disease and a normal full field ERG, there is an 80% chance you will retain a normal ERG at 10 years follow-up. If you present with a cone or cone rod dystrophy, then invariably the ERGs get worse over time. So the prognosis for retention of paracentral vision is much better in Stargardt disease if the full field ERGs are normal. And many patients here at Moorfields Eye Hospital are counseled on that basis. So ABCA4 can result in widely variable phenotypes. So can we look at genotype-phenotype correlations in any more detail? Well, it's actually very difficult in Stargardt disease because the gene responsible is large and more than 1,000 different variants have been described. And that's more than 1 million possible biallelic variants. So very difficult to establish, specific genotype-phenotype correlations. So one approach is to classify variants according to their predicted severity. So for example, patients with 2 null variants you'd predict would have no protein expression. Whereas if you compare this group with another group with only 1 null mutation, you can then judge the impact of the other variant. And as an example today, I'm going to compare a group that harbors this 1961 missense point mutation, the commonest variant in Stargardt disease. So you can see in nullizygous cases with 2 null mutations, the median age of onset is early childhood. But if patients harbor the 1961 change in combination with a null, the median age is older, 17 years. So there's later onset. Double null mutations tend to result in progressive, widespread maculopathy over 3 or 4 decades. But patients that harbor the 1961 change have much more focal changes and show less progression over 4, 5, 6 decades. So what about the ERGs? Well, this is from our old reference range, our normative database from about 10 years ago. And you can see that, with increasing age, ERGs tend to become smaller. It's just the normal aging process. Nullizygous patients have abnormal ERGs at a young age, and there's age-associated decline in both the dark-adapted and light-adapted responses. Whereas if you harbor the 1961 change, the ERGs are normal, irrespective of age. So that's in keeping with the longitudinal data and in keeping with the structural, the fundus autofluorescence data as well. So just one method that you can use to establish sort of the impact of specific allelic changes. Okay, I'll move on to a second case, a 30-year-old man with a 15-year history of visual loss, but normal fundi. And there's a possible dominant family history. So the fundi are normal. The autofluorescence shows no gross change. The pattern VEPs are actually subnormal, so you might be a little bit concerned about optic neuropathy, except when you perform the pattern ERG, P50 is reduced. Compare that with this normal example. So evidence of bilateral macular dysfunction that likely explains the pattern VEP reduction. So maculopathy or macular dysfunction, not optic nerve dysfunction. So is the generalized retinal involvement? Well, there's no ERG evidence of that. The full field ERGs are normal. And consistent with the pattern ERG, the multifocal ERG shows severe but highly localized central macular dysfunction. And in fact, this phenotype prompted the genetic screening. Sanger sequencing was performed, and this patient has occult macular dystrophy due to this heterozygous change in RP1L1. An OCT is often useful in this condition because they can show often quite laterally extensive but subtle irregularity of the ellipsoid zone, and occasionally they also show subfoveal cavitation. A bit like in this patient, where there's very distinctive subfoveal sort of cavities. This is a 13-year-old boy with reduced vision, a central scotoma in the left eye. You can see there's some juxtafoveal changes, worse in the left eye. The full field ERGs are normal, like in the last patient. The left eye multifocal ERG is also very similar to the last case, but relatively preserved on the right. It's not normal, but the central response is better preserved on the right than the left. So there is bilateral but asymmetrical macular dysfunction. And in fact, in this case, before the patient came to Moorfields, they underwent genetic testing, and there was a positive result. This patient has a missense change in the TIMP3 gene. So does this patient have Sorsby macular dystrophy? Well, of course, this mutation might be irrelevant to the maculopathy. And it transpired that he'd been playing with a laser pen, and this is an example of laser retinopathy. But just highlighting that the genetic data can sometimes be misleading, and sometimes the phenotype is more important to establish the diagnosis. This 18-year-old has myopia, lifelong nyctalopia. A maternal male cousin is affected, so it sort of suggests an X-linked inheritance. There's myopic changes, also evident on autofluorescence imaging, and there's some sort of myopic distortion, but the lamination is intact. And the ERGs, in spite of the normal appearing OCT and fundus, were markedly abnormal. Now, the patient was 18 when those images were taken. He actually underwent electrophysiology much earlier, when he was 5 years old, using these skin electrodes. And can you see how the scotopic bright flash ERG is electronegative? The B wave is smaller than the A wave, indicating inner retinal dysfunction, or at least dysfunction after phototransduction. The flicker ERGs are reduced, delayed, bifid, with a twin sort of peak, and the single flash cone ERGs also have a very low B to A ratio. And I thought, these ERGs, they're a bit noisy because the skin electrodes and the patient's only 5, but I thought most in keeping with one disorder. And some of you might recognize this ERG phenotype, but I thought this was consistent with incomplete congenital stationary night blindness. And really important to distinguish this from progressive causes of night blindness, like retinal degeneration or retinitis pigmentosa. And just to highlight incomplete CSNB, the dim flash rod ERGs are incompletely attenuated, the strong flash ERGs electronegative, and there's marked cone system dysfunction. And we know the reason why there's such severe cone system dysfunction is because the 2 genes that are associated with this disorder are both expressed on the presynaptic membrane of the photoreceptor. And so they affect glutamate release, and so you get both cone on and off bipolar cell dysfunction. Whereas in complete CSNB, there's much milder cone system dysfunction because the genes responsible are all selectively expressed in the retina, at least, by the on-bipolar cells. So anyway, the patient, had this provisional diagnosis, whole genome sequencing was performed, and no genetic cause was identified. So is this another disorder? Well, I thought, these ERGs are so distinctive, then maybe it should prompt another re-examination of the genotype. And so that was done. And they actually found a filtering error, I should say, in the in the gene analysis. And that prompted further sequencing, and further probing did actually reveal a CACNA1F variant. This is X-linked incomplete CSNB. But just highlighting whole genome sequencing is not always 100% accurate. Okay, a 27-year-old with poor central vision since primary school age, 636, 660 vision, the beginnings of a bullseye lesion bilaterally. There's generalized cone system dysfunction with unusual rod system involvement. Responses to the dimmest flashes are attenuated, but to the strongest flash, almost augmented, with a flattening of the A wave trough. And if you're not used to looking at ERGs, it's quite difficult, but actually to an electrophysiologist, these ERGs are pathognomonic for one disorder. It specifies the gene responsible for this disorder, and it's actually KCNV2. This is an example of KCNV2 retinopathy, historically referred to as cone dystrophy with supernormal rod ERG. And it's a recessive condition. There's early onset myopia. There's an association with high myopia. Patients typically present with reduced vision, and unusually, for an early cone dystrophy, there can be nyctalopia as well. And there can be a range of macular appearances. So I've arranged these in age order. The first patient's 10 in the top left corner. The patient in the bottom right is 60, and you can see in this cross-sectional survey how maculopathy tends to develop with time. The ERGs are pathognomonic irrespective of the fundus appearance. And it's quite common in this disorder to see subfoveal cavitation, but nothing specific about that. It can occur in achromatopsia, in some forms of incomplete CSNB, in Stargardt disease, and occult macular dystrophy. And the ERGs can help make the distinction. Okay, this is the last case. It's a 16-year-old, slightly reduced vision down to 6'9", and he was referred from elsewhere with macular lesions, which are more obvious on fundus autofluorescence imaging. So what are you going to include in the differential diagnosis? There's macular schisis in both eyes, and it was suspected that this was X-linked retinoschisis. And full field ERGs were performed, and they were normal. And that is not typical of X-linked retinoschisis. Pattern ERG P50 is subnormal bilaterally, mildly subnormal, so there is evidence of macular dysfunction. And around the same time, they did perform Sanger sequencing of the RS1 gene, and the patient tested negative. So this is not X-linked retinoschisis, where you expect an electronegative ERG, a B wave smaller than the A wave. What else could it be? Well, macular schisis can be associated with enhanced S-cone syndrome, seen in about 40% of cases. But enhanced S-cone syndrome is another one of those disorders where the ERGs are so distinctive, they specify the diagnosis. You can see schisis in other disorders, such as autosomal recessive bestrophinopathy. No signs of that in our patient. But could it be CRB1 retinopathy, where you can have a variable phenotype? Some patients have Leber congenital amaurosis, some have retinitis pigmentosa, some have macular dystrophy, all related to mutations in the same gene. And interestingly, about 40 to 50% of patients with RP and macular dystrophy with CRB1 related disease can have macular schisis. So fairly recently, I reviewed about 30 cases of CRB1 retinopathy. And this looks complicated, but it's not. I've just plotted the main ERG components as a percentage of the lower limit of normal, just to make the rod and cone mediated components directly comparable. And I've arranged these in ascending order of ERG A wave preservation, just to better visualize the wide range of dysfunction. So the first 7 patients have undetectable ERGs. These patients have similar rod and cone system dysfunction. These patients have essentially normal ERGs. In other words, they have a macular dystrophy. Now, clinically, when these patients were first examined, these cases were suspected of having Leber congenital amaurosis. These patients were thought to have retinitis pigmentosa, and the rest were thought to have a macular dystrophy. But the ERGs tell us that there is generalized dysfunction in some of these cases. Only the last 8 or 9 patients have a true macular dystrophy with normal ERGs, and all of those patients harbor the same in-frame deletion that confers a much milder phenotype. So an example of where the ERGs have helped establish a genotype-phenotype correlation, and in fact, our 16-year-old patient had the same change, the same variant, the same deletion. Okay, just to summarize, retinal structure and function do not always correlate. ERG phenotyping can aid diagnosis, prognosis, and in some circumstances can direct the genetic testing. ERG phenotypes inform interpretation of variants and may suggest missed variants. Genetic testing is sometimes inconclusive and it's not always available. Even when it's done, it's not always available. And I think, I'm hoping that I've illustrated the importance of accurate phenotyping. Thank you.
So thank you so much, Professor Robson. As usual, very interesting and impactful. So now I would like to invite our Vice Counsel. So Subhadra ma'am, could you please comment on the talk, and in case if you have any queries, any suggestions on your experience? I mean, you are the senior most in India, who've been
My
doing
white
this,
hair,
teaching us.
same as Tony's. Okay, no, one thing is there, see, when we are teaching this ERGs and all, one thing which confuses many students, and I have to be actively thinking, is this incomplete and complete. Because intuitively, it seems that the incomplete is the complete one, and the complete is the incomplete one, so we have to keep on reminding ourselves, no, it's the other way around. So Tony, maybe for the, benefit of all the people, you can retell
Yes.
what is complete about the complete and what is incomplete about the incomplete.
Oh,
As far as the
absolutely.
phenotype is concerned, to me, most of the incomplete ones have fine nystagmus and they have little low vision, whereas the complete ones in general have better vision, like 20/20 or something, and they don't have fine nystagmus. But that's the clinical part. But the ERG part, if you can,
Yes, absolutely. I'll just try and share my screen again.
because it's always weird.
I
think you
can't
had
see
the
it.
slide where you showed that,
I-
one is like pre-synaptic, one is localized to the on-bipolar cells. Maybe that slide.
Yeah, like
Yes.
it's always
Okay.
very, very,
Okay, got it. I've got it.
yeah.
Oh, it won't let me share. Odd. Okay, so I'm sorry, I can't. For some reason, I can't share it. But complete and incomplete CSMB. So first of all, I think incomplete CSMB is a little bit of a misnomer because about 50% of those patients actually complain of day vision problems. It's almost like a stationary cone dysfunction syndrome with electronegativity and with some patients complaining of night blindness. In complete CSMB, the reason it's called complete is because the dim flash rod ERG is completely attenuated. So even though there's milder cone system dysfunction consistent with selective on bipolar cell dysfunction, Under dark adapted conditions, the dim flash RODI-RG is completely attenuated and patients' dark adapted thresholds are elevated. In incomplete CSNB, the dim flash RODI-RG is incompletely attenuated. It's usually detectable, but it's subnormal. So that's sort of a way of reminding yourself of the distinction between complete and incomplete CSNB. But often, as I say, patients with incomplete CSNB often complain of, photophobia and poor color vision and poor visual acuity, day vision problems, as well as night blindness.
Yes, ma'am.
Yeah,
I do agree. In fact, in sometimes when, as Subhadram rightly mentioned, incomplete, sometimes it's quite confusing clinically. They look like achromatopsia. They'll have photophobia, color vision is abnormal, nystagmus. It's only when we do an ERG we get to know it's not an achromatopsia and it's a incomplete CSNB because even in achromatopsia we'll see that normal fundus, normal OCT, and all that. So that's where electrophysiology is extremely useful. So Rajini madam, you wanted to come in.
Uh, I have a comment. Oh, thank you, Tony. That was, as usual, brilliant. Thank you. No, so this is about the whole genome sequencing that he showed a patient where, they couldn't pick up the incomplete CSNB mutation, initially. So I don't know what the experience of the, general group is. In those patients where we've done a whole exome sequencing, I've actually had not a great, response with whole genome sequencing. When you have a negative whole exome sequencing, I've not had a great result with whole genome sequencing. I do think that while our sequencing is okay, I think there's a lot to be really done in the bioinformatics field probably. So I don't know what the rest of them feel, because I've had a couple of children where whole exome was negative, did a whole genome, and sort of came up with something that was syndromic. The whole genome picked up, and I had to reassure the parents that no, your children don't have these, so I don't think so. And almost about 6 years later, had to do a research project where we identified that the whole genome sequencing report was completely wrong. So I don't know what the rest of them would feel about doing whole genome sequencing routinely where the whole exome is negative.
I do agree with we just do come across these situations, and coming to the whole genome, the cost becomes a little limiting factor over here. And personally, I don't do that often the whole genome sequencing, so my experience is little limited. Maybe I'll request Parveen ma'am, Shrikanta, Deepika to comment on this thing. It's I think as you rightly pointed out, it's more we need to invest more on our bioinformatics and then maybe come up with that could be the solution. So Shrikanta, Parveen ma'am, I mean, would you like to comment on that?
Yeah, so I think I agree. I don't really jump to a whole genome sequencing right away because it throws up a lot of uncertain significance and you don't know how to
Yes.
interpret them. So usually my stepwise thing is that after a whole exome sequencing, I look for some clues if there are some like variants, something which has been reported as a variance of unknown significance, look carefully into it, whether that can be further extrapolated or whether you could look at a trio, look at the whole exome sequencing of the parents, or look at if I'm very sure of my clinical phenotype, then depending on my clinical phenotype, look at that specific gene, whether that could be found somewhere. And especially for, Septo90, I had a patient who had um, rod cone dystrophy along with a kidney problem, but we could not pinpoint which disease, which genetic mutation it was. But they had reported a Septo90, a single variant that they had found, so which became US. But then the clinical phenotype quite matched it. So we further looked into the specific intron, specific variant. So little bit of that homework before you straight away jump into whole genome is, I think, sometimes more useful. And the whole genome sometimes may not always give you the answer. And of course, as Dr. Purna said, it throws up a lot of unknown variants. But I think Dr. Robson would be a good person to tell more on this because they do whole genome sequences on a regular basis. So probably you would be able to tell us better how you interpret your results.
Yes, I mean, I must put my hand up and say, I'm not a molecular biologist, and we have people to do that for us. But I think it does throw up problems and questions, and I think accurate phenotyping can help establish the significance of some of the changes that are identified. But yeah, it's difficult in some circumstances, and certainly, in the UK, we don't automatically perform whole genome sequencing. There's some disorders where we perform Sanger sequencing, Best disease, Doyne's honeycomb, macular dystrophy, RS1. Often the phenotype is so suggestive, you just screen those genes. But yeah, I'm not sure I can
Thank
say
you.
more. I'm not a molecular biologist, so.
Just a comment about
And
the previous Dr. Subhadra had mentioned about the complete and incomplete. I think incomplete is very, very difficult to diagnose. Most of the times it is diagnosed as a cone rod or a rod cone dystrophy rather than a CSMB until unless you really do genetic testing in those cases. And I think I would like to know your opinion. Some of them are mildly progressive as well. So I don't know whether it's time to rename incomplete CSNB in some way, because we had seen few of the patients and even published, I think, the SLC mutations, some of the incomplete ones are mildly progressive, especially a little, those autofluorescence, if you see, they do come up with increased areas of hypoautofluorescence when you see on the follow-up. It's not completely normal
Yes,
fundus.
yes. So do you think sometimes that's just a long-term consequence of high myopia?
Yeah, I was just going to say that because
that's
that
exactly,
confounds my ERG also. Sometimes they have high myopia, and then if I'm not able to interpret, then I try to do a visual field. At least if the fields are good, then, then I think that, okay, this is not a rod cone dystrophy which I'm missing, or a cone rod dystrophy, where usually you would find significant field loss. But in the incomplete CSNB, if they can do a fields, at least the peripheral fields are good. Then
Yes,
I think that, okay, this is possibly not a
yes.
cone rod or rod cone dystrophy. But yeah, sometimes, even the negative ERG may not look that negative because they have very high myopia sometimes.
I mean, I think in my experience, high myopia can attenuate the A wave, but usually, at least from the cases that I've seen, they still have a markedly electronegative ERG, less so in incomplete CSMB maybe, but in the complete
Yes.
form. So I've
Complete.
just realized I can't share my screen using one of the icons, but I can with the other. So if you like, I can share that slide again. Can you see it?
yeah,
It's coming.
it's coming. It's coming.
Okay,
Yes, we can see.
so complete CSMB, you can see the dim flash rod ERG is undetectable. The strong flash ERG is electronegative. There's a subtle flattening of the trough, not always present, but often between the adjacent peaks in the flicker ERG. And there's a very distinctive single flash cone ERG with a broadened bifid A wave and a sharply rising B wave. And that's what an ERG looks like in the absence of on-bipolar cell dysfunction. And that's confirmed with something called an on-off ERG that shows selective on-B wave reduction. And we can relate all of those changes to the protein expression, which is in the on-bipolar cells. Incomplete CSMB, you can see the dim flash rod ERG is attenuated. The strong flash ERG is electronegative. On average, I think the electronegativity is a bit less than in complete CSMB, although there's overlap. And the flicker ERG is much more markedly affected than in the complete form. And as I mentioned earlier, that's because there's both on and off bipolar cell dysfunction, because the two genes implicated affect glutamate release from the presynaptic membrane. But I think, the dim flash rod ERG is completely attenuated here, incompletely attenuated in incomplete CSMB.
Thank you so much, Professor Robson, for taking your time to share the screen again and explaining it. So thank you so much. So basically, the take-home message is you should look more into the deeper phenotyping than switching from one test, as he rightly mentioned in one of the case where there was a filtering error, he strongly suspected Kakna, and then finally they got it. So thank you so much. So next we have an interesting cases lined up for the discussion. So first I would like to invite Dr. Soumya Johari to present a case titled X-linked retinitis pigmentosa clinical clues to diagnosis. So over to you, Dr. Soumya. You can start sharing your screen.
Please unmute yourself, Soumya. Good.
Yes, sir.
You can go to the full screen mode.
Yes, sir. I hope that's visible.
Yes.
Okay.
Yes, it's
Hello,
visible,
everyone.
audible.
Oh, perfect, sir. So, hello, everyone. I'm Soumya, VR fellow from Narayana Nethralaya. And at the outset, I would like to thank a lot to the VRSI platform for giving me this opportunity. So today I'll be talking about X-linked retinitis pigmentosa and the clinical clues for its diagnosis. So the talk will cover the following objectives: the retinal phenotype in affected male of X-linked retinitis pigmentosa, the X-linked pedigree and its clinical implications, the RPGR, RP genetics, and the retinal features in carrier females of XLRP. So we'll start with the case. We had a 31-year-old male who presented to us with complaints of night vision difficulty and peripheral vision loss from the age of 5 years. It was gradual onset and progressive, with no systemic or medical history. So coming to the pedigree overview, when we saw his genetic, pedigree charting, we saw that there were multiple males affected from the maternal side. So, and there were no affected females, which raised a suspicion of an X-linked recessive inheritance. Coming to the anterior segment examination, he had a BCVA of 6/18 parts in both the eyes, and on refraction, he had a high myopia of around -8 spherical and -2.5 cylinder in both the eyes. On fundoscopy, it showed myopic disc with tessellated background, bony spicules, attenuated vasculature, and RP mottling. On fundus autofluorescence, sorry for the technical error. So fundus autofluorescence, there was bilateral hypo-AF surrounding the hyper-AF fovea with multiple hypo-AF patches in the mid-periphery. On OCT, we saw there was a marked outer retinal thinning with loss of EZ along with the myopic counter. So we went ahead with clinical exam sequencing in this patient. And on genetic results, he tested positive for a likely pathogenic hemizygous termination variant in the exon 5 of the RPGR gene, which is known to cause retinitis pigmentosa 3 in an X-linked recessive manner. So our final diagnosis was RPGR-associated X-linked retinitis pigmentosa. So coming to the salient features of the entity, but before that, I think it's very noteworthy to see that in 1975, Professor Bird had reported that X-linked retinitis pigmentosa is a distinct entity from choroideremia and is much more common than has been previously reported. And not long ago, that is in 2017, the first person in the world received the gene therapy for X-linked RP. So we have definitely come a long way. So putting it all together, there's early onset night blindness and peripheral visual loss that is usually by the end of first decade. It's much more common in males. There's an early and often severe onset of high myopia. There's eventual central vision involvement as well. In the pedigree, we'll usually see males are affected and females are carriers. Males will have a very severe phenotype, and on electrophysiology, we'll usually see diminished or absent responses. So coming to the RPGR1 gene, normally 10 to 20% of retinitis pigmentosa cases are X-linked. Out of these X-linked cases, 70% of X-linked retinitis pigmentosa cases are associated with RPGR gene mutations. Out of these RPGR gene mutations, again, 60% of them are attributed to the mutations in ORF15 gene, which is also known as open reading frame 15, and it's a mutational hotspot. So coming to the inheritance trait, in the first scenario, we'll see the classical X-linked recessive inheritance, where there's an unaffected father, there's a carrier mother, and we can see that there's a 50% chance that the daughter will be the carrier and a 50% chance that the son will be affected. In the second scenario, we can see that the father is affected, mother is unaffected, all the daughters will be carriers, however, no son will be affected. So genetic counseling definitely plays a pivotal role in both the scenarios. Now, till now, we saw that the females were merely carriers. We come to another scenario where we had a patient who was 22-year-old, known case of RP with a full-blown phenotype, and again with childhood onset of symptoms. When we saw his pedigree, we saw that apart from the conventionally that males are affected, 2 female relatives were also affected. So, on a superficial glance, this can be confused for autosomal dominant inheritance as well. He tested positive for RPGR deletion gene, actually. So again, this manifestation of phenotype in females is explained by something called skewed X chromosome inactivation. So normally in females, in each cell, one of the X copies will get inactivated, but this is very random, and which is what it maintains a ratio of 50 to 50 and helps in masking the phenotype in the carriers. But when it's skewed X chromosome inactivation, what happens if there's more expression of the mutant allele, the disease will get expressed in the carriers as well. So skewing essentially unmasks the phenotype in the carriers, and XLRP is actually a spectrum. Now, even in females, we can see that there are different phenotypes in the carriers. So again, we had another scenario where we had a mother who was 38-year-old. She was a manifesting carrier with a full-blown RP picture, tested positive for RPGR gene, and she had a family history of RP also. Both her mother and brother were affected. But when we see the daughter, who was 4 years old, completely asymptomatic and with no obvious findings, she tested positive for the same mutation, but there were no full-blown findings as of then. However, in fundus autofluorescence, we can see that there's a radiating hyperautofluorescent, tapetal pattern from the posterior pole, which is a distinctive feature of the carriers of X-linked RP. So the take clinic points are that RPGR-RP is the most common form of X-linked RP. Affected males will have early onset and severe phenotype. The X-linked pedigree, in that males will be affected classically, with females being the carriers usually. And even in the females being carriers, some of them will be asymptomatic and some of them will manifest. So that will be the end of my presentation. Sorry for the technical glitch, and thanks for your attention.
Soumya, you could keep your screen sharing on because we may have to go back to a few of the slides. Excellent
Sure, sir.
presentation and collection of cases. Okay, so for one thing, before going to the comment from Vice Counsel and Professor Robson, and X-linked pedigree, when you're trying, you have to be very careful. Most of the time, the females, because of this carrier state appearance, they have been falsely labeled as, having a dystrophy or outcome dystrophy. It's very important. They'll always tell it is, of course, affected. It's very important we call them and we examine them and be sure that it's not because of the carrier status. It's actually affected. That's very important. So, Professor Robson, your comment on the presentation and inputs.
No, very nice presentation. Thank you.
I just wanted to ask one small thing. Tony, you're going to say something, sorry.
Yes, I was. I was just going to say that, the ERGs are often useful in identifying carriers of X-linked RP because the fundus phenotype can be variable due to random inactivation. But unusually, for an inherited retinal dystrophy, the ERGs are often asymmetrical and quite markedly asymmetrical in some cases. And that's unlike carriers of choroideremia, for example, where the ERGs tend to be normal in carriers. But the asymmetry can sometimes give a clue to the diagnosis. And the asymmetry is seen both in terms of amplitude and flicker ERG peak times. And I think, when we reviewed about 40 or 50 cases, about 90% of those over the age of 40 manifested obligate carriers manifested ERG abnormalities. And just also to highlight, RPGR can be depending on where the variant is in the gene, it can also cause an X-linked cone rod dystrophy. But thank you. Very nice presentation.
Thank you so much.
Deepika, would you like to sorry, Subhadra ma'am, you wanted to comment something?
But a small thing I wanted to ask, maybe Deepika would know better. what was said was that 10 to 20% are X-linked RP out of all the RPs. But I'm not sure that is true for our population, because I, very occasionally see these X-linked RPs, and there's a lot of sporadic or, autosomal recessive. So Deepika had done some studies on large data sets. So do we think that in India also the X-linked RP constitutes 10 to 20%, or is the group smaller because it is overwhelmingly recessive or sporadic?
Okay. Yeah. Thank you, Dr. S.C. Yeah, this 10 to 20% data is from across the world, not specifically to India. But if we see the occurrence of RP and their percentage with respect to the pattern of inheritance, even across the group, autosomal recessive comes first. Then we have autosomal dominant, X-linked. In our population also, we have seen the similar pattern of inheritance and proportions. I'm not sure whether we are missing some of the RPGR cases. Even I have seen very few RPGRs. Shrikant has a series actually of RPGRs. So I believe we do have cases of RPGR. Exact percentage, definitely I'm not sure. And we might be missing some of the RPGR if the open reading frame 15 is not sequenced by the lab. So we might be getting negative results for a suspected X-linked RP. So we have to look into that aspect as well. I feel. Yeah.
Thank you, Deepika. I think one comment is from Rajini ma'am, then followed by Srikanta.
So I actually had a question for either Tony or anyone else, because there was a clinical trial for RPGR. I think Meera used to run it, and I remember Mike from Moorfield saying that they've actually had good results. And an interesting bit was that they had not seen the the area of atrophy that's been seen with Luxturna. So there's always a doubt whether that was because the viral vector or the surgery. And I remember him telling me that they had not seen this area of atrophy in about 100 patients with RPGR. So just wondering if Tony has any information on that.
No, I don't think I can comment on that, I'm afraid.
Okay, that's all right. Yeah. Thanks. Yeah.
Srikanta, you wanted to comment?
Yeah, quickly. So compared to the southern part of India, what I have seen in the eastern part of India, most of our RPGR cases, they present like cone rod dystrophy. So like the female carriers, what we classically see this capital like reflex. So I see in most of my patients who were initially diagnosed only either as macular dystrophy or as cone dystrophy based on ERG. Later on, they were diagnosed, especially in males, majority of them were males. Later on diagnosed to carry this RPGR gene positive. So probably there is some maybe population changes compared to eastern part or southern part of India, where and the majority of cases in the southern part of India are probably rod cone type of dystrophy, whereas in the eastern part of India it is cone rod type of dystrophy, especially in males.
Also, when it
So
comes
for
to clinical
RPGR, what I have seen is RP and rod cone dystrophy phenotype here, the genetically positive one. I'm yet to see a cone rod RPGR. I mean, I don't have a large series, so it might be false as well.
RPGR is little difficult. Again, the gene is very large. I mean, I was also very curious in knowing what happened to the trial, what Rajini ma'am was asking. It's very, very curious. It's like, ABC for very complex. Sometimes the coverage, as Deepika clearly mentioned, if it's not covered, it may be missed. So that's something which we have to keep in mind. And if you have a strong suspicion, better we communicate that to our geneticist and the team so that they look into that in that area in detail. Fine. Thank you so much. We had an excellent discussion. So, Soumya, you can stop sharing screen. So now I would
Yes.
like to invite Dr. Divyansh Rukwani. She'll be presenting on retinal cavitation in enhanced Eskon syndrome. So over to you, Dr. Divyansh.
So, yeah, am I audible clearly and my slides visible?
Yes, you are audible. You can go to full screen mode.
Yeah.
Perfect. Yeah.
Yeah. So, thank you everyone. Good evening again for letting me present this interesting case where we try to describe a novel phenotypic characteristic in three of our cases, which is a retinal cavitation lesions in cases of enhanced S-cone syndrome. So I'm Divyansh and I'm from VR fellow at LV Prasad Institute, Bhubaneswar. So before going into our case, just a background of common phenotypic characteristics which are commonly seen in this syndrome. It was described by Goldman and Fever in 1958, where they had first described it as a pigmentary retinal dystrophy with hyaloid retinal degenerations. It is a rare autosomal recessive disorder, and the common mutation that is seen is in the NR2E3 gene, which is a transcriptional factor protein used for the differentiation of various cones. And when the lineage shifts from the rod to the S cone, that's why we get the name of enhanced S cone disease. The common symptoms are usually early onset, nyctalopia, and blurring of vision, especially seen in the second decade of life. Clinically, we see these pigmentary nummular changes, which may early on, they might be small pinpoint pigmentary changes, and later they become more of a nummular pigmentary changes, usually described in the mid-peripheral lesions, where more of the S cones and the rods are concentrated, and around 70% of the cases show this kind of macular sciatic cavities, which might be a dome-shaped macular schisis or a broad-based schisis. Some cases might also describe these classical yellow lesions, which are more characteristically distributed nasal to the disc and inferiorly. And on autofluorescence, these are seen as punctate hyperautofluorescence lesions in the mid-periphery. And sometimes these may also present as a helicoid or a circumferential subretinal fibrosis lesions with secondary choroidal neovascular membrane formations or a retinal neovascular membrane formation. The schisis that we see at the macula involves the sciatic cavities, which are more or less located in the outer plexiform layer, as you can see in this optical coherence tomography. The pathognomic ERG described is that of a dark adapted 0.01 being absent or extinguished, as you can see in this image. There's also decreased amplitude and increased implicit time in the dark adapted 3.0 and 10.0. And even the light adapted responses are severely delayed and reduced in amplitude, as you can see in these ERG waveforms. It is important to note that the light adapted and the dark adapted 3.0 in these lesions is usually similar, and the 30 hertz flicker that is more or less specific for the cone response also shows severely reduced amplitude of the A waves. And according to the extended ICIF protocols, when we do a S cone specific response, which is this wave here, we can see that there is enhancement or broadening of this S cone response and the abnormal attenuation of the L and M peak as compared to the standard waveforms. So, coming to our case, we have a 17-year-old male who was resident of Rajgangpur, Odisha. He had both eye blurring of vision with nyctalopia. He was born out of non-consanguineous marriage, and the D15 test for him was normal. The best corrected visual acuity was 20/80 in both eyes, and he was emmetrope in the right eye with a mild astigmatism in the left eye. Usually, these cases have been shown to be hyperopic, but in this case, we had emmetropic refraction. The classical fundus photo that we see of a normal disc with almost normal vessel caliber with some yellow granules seen nasal to the disc. But to our surprise, we could see these hypopigmented cavitary lesions, as you can see here, distributed more or less in the mid periphery along the arcades and nasal to the disc, which are bilaterally symmetrical. So these are oblong-like hypopigmented orange to yellow cavitary lesions that we saw in all of our three cases, and we hypothesized them to be a cavitary lesion. These were much better delineated on the red-free images. As you can see here, these oblong lesions are much more as compared to what we saw on the fundus photography. And to our surprise, in cases of fundus autofluorescence, we could not delineate these lesions, but we could see some punctate hyperautofluorescence, which were more or less corresponding to the yellow granular lesions rather than those cavitary lesions. And again, the macula showed chytic cavities, which were located in the outer plexiform layer. When we passed a horizontal line scan through these cavitary lesions, as you can see here, we could see that hyporeflective cavitary lesions are located more or less in the inner retinal layers, that is in the ganglion cell layer, as you can see here with pointing at the white arrows. So again, we got the characteristic ERG where we had an extinguished dark adapted 0.01 waveforms, a delayed and low amplitude waveforms in dark adapted 10.0 and light adapted 3.0, and even delayed low amplitude waveforms in 30 Hz flicker cone response. And again, the S cone response, which shows an enhancement or the broad wave and an attenuated V wave for the L and M codes. The whole exome sequencing showed mutation in the NR2E3, which was homozygous mutation and likely pathogenic, and the inheritance was autosomal recessive. And this correlated on the pedigree chart where we see that the mother and father of the child were carriers and the other child was normal. This is because of the autosomal recessive inheritance that was seen in our case. Even the second case had similar findings where we see these oblong, round cavitary lesions which are hypopigmented seen on fundus photograph. And again, these corresponded to these round hyporeflective spaces or cavitary lesions in the ganglion cell layers and few in the outer plexiform layers as well. And again, a genetic analysis showed us a missense homozygous mutation in NR2E3 variant of exon 3. Again, our third case, which was a 27-year-old male, similar history of nyctalopia with a best corrected visual acuity of 2050 in the right eye and 2020 in the left eye, showed similar macular dome-shaped chysis with oblong cavitary lesions more located temporally along the arcades. And here you can see in the OCT line scan where these cavitary lesions are more or less located in the inner retinal layers with a NR2E3 missense variant mutations, which was homozygous. So in all our three cases, we could see that these cavitary lesions are actually seen at the area where classically described pigmentary changes or nummular pigmentary changes have been described. So I would like to ask the panelists that what are their views, that do you think these are precursors to the pigmentary changes? And also we saw that there is a structural and functional dissociation between the autofluorescence and the fundus imaging. That is, these lesions are not picked up on autofluorescence, which are more of a functional test as compared to the structural fundus photo and an OCT. So what are your views on that? Thank you.
Thank you so much, Dr. Devansh, for the nice presentation. And this presentation and the kind of cases what you showed is very relevant considering the target audience what we have today. Because most often these cases gets misdiagnosed for many other things when we get a referral. So that's very important. And this is only other few of the disorders other than KCNV2 where ERG could be diagnostic. You need not even go for a genetic testing. You can just go back to the previous slide where you displayed the questions. I would like to invite Professor Robston to comment first, followed by other vice counsel.
Well, thank you. That's a really interesting and very nice presentation. Very interesting indeed. So I think, the ERGs in enhanced Escon syndrome are pathognomonic, as you say. I think it's important to measure the peak times and amplitudes, but I also think what's really important is to look at the waveform shapes, because sometimes the amplitudes can be misleading. And if you do a survey of a large number of enhanced Escon cases, it's surprising how large some of those abnormal ERGs actually are. And it's the waveform shape and the relationship between the different components, the single flash cone ERG and the flicker ERG, for example, that gives the diagnosis. And another interesting thing is, if you do a cross-sectional analysis over 6 or 7 decades, even though the ERGs are on average smaller than normal, the rate of age-associated ERG reduction is very similar to what you see in healthy individuals. So I think in many cases, if you start off with a large ERG, it doesn't seem to be a very aggressive peripheral retinal degeneration, although maculopathy does develop. So that is interesting. And as for whether these changes are precursors to pigmentary changes, I don't know. You could speculate. I think it'll be very interesting to follow these cases over time and see what happens.
Thank you so much, Professor Robson, and your comments on these questions, what he has put.
Yeah, I don't know. You can speculate. I can't think of any
I don't think
any
we can have a
mechanism.
clear answer for this.
Yeah.
So Divyansh, you picked up these lesions for the first time. Have they been described in literature? Is it that we need to go back to our images and try to search? have we missed these lesions, or maybe we are seeing them only at the pigmentary stage, so then they won't be visible? So, so on your literature search, did you find this type of lesions in any other condition, or has anybody else described it in enhanced Escon syndrome?
I could not find these. That's why we wrote it in a manuscript as novel. But these some cavitary lesions have been described in other conditions, like in CRB1. I found some case reports, but in enhanced Escon, I've never. In the literature, no one has mentioned these kind of.
So those cavitary lesions which you found in CRB1, they were also in the nerve fiber layer predominantly, and did they lead to pigmentation or something like?
No,
What was the
there
interpretation
was
there?
no correlation with the pigmentary changes in that.
Yeah, so maybe now we'll all rush and see our enhanced Escon syndrome pictures back, or we don't have OCT through that area because it's more likely that we have OCT through only the macula. So I think it will be interesting for us to look out for this novel finding and see, what it is. I have not known about this, or at least I haven't seen, or as obviously it is that maybe we are missing. We are concentrating on the macula and the the schisis and other things. So yeah, it will be interesting to see whether we see this in other disorders.
Sure.
Can I make a
Definitely, we need
comment,
to look.
Dr. Purna?
Okay,
Yeah,
please,
Praveen, go ahead.
please.
So actually, I'm only thinking very good observation, but then since this patient was young and we have noticed things like torpedo-like lesions in enhanced Escon and in NR2 E3 mutations. And if you look at the pathophysiology, it is that you have those the precursor Escons are present, and it is only later in the development that the normal L and M cones do develop. So probably it is those immature Escons which are present, which are looking like this, and since I wouldn't probably call it a cavitary lesion. It's like as if those areas the cells are absent. There is a structural absence of cells, and probably it affects the surrounding Muller cells as well. In fact, when I saw your case, I thought cavitary lesions you would somehow talk of like focal excavations that you see. I think in CRB1 also that you mentioned, it's more like a focal excavation rather than these are present probably in the nuclear layer, and they are hypoechoic as if there is an absence of cells in that area, which could probably relate to the pathogenesis of how this disease um, happens, because they're only rudimentary, or the S cones which are present, and they don't differentiate into the better and more evolved L and M cones. And whether these are precursors of the tornado lesions, that's a
Dr.
possibility.
Brijesh, you wanted to comment?
Yeah,
Dr.
thank you,
Brijesh,
Poorna. Can you hear me? Hello?
maybe his screen is frozen.
Yes, Brijesh, go ahead. We can hear.
We can hear. We can hear.
Yeah, so what I was trying to suggest was, first of all, very exceptional cases, especially the last one. It seemed like a super enhanced Hescone syndrome to me rather than only enhanced.
Yeah, you
But
can put those pictures back for the time being so that we can savor them some more.
So
Yeah.
my
Put the
thought
pictures,
on the
Divyansh.
my thought
Yeah.
on
No,
uh,
Divyansh, I
go
was
to
saying you
the
can put the pictures for us for the time being. Yeah, go ahead,
Yeah.
Divyansh. No.
yeah, so my thought on your second question was that, see, we are having schisis at the center of the macula in ESCS, and some of the so-called cavitations that you see are also in the similar layers. So is it possible that the same mechanism was happening, what happens at the macula, whether the similar thing is happening in the lesions where you have taken OCT from? So it may just simply reflect the severity of disease was more in that particular case where you were seeing this so-called cavitations external to macula also. So if you can look at the mechanism behind macular schisis, it may just give you the answer. The other thing is that the fact that red-free showed better morphology than autofluorescence. See, that's because these lesions are in the center. So in those particular areas, I think the photoreceptor RP function is not that much affected. That autofluorescence gives you a change. So mostly that is the reason why you see them better in the red-free as compared to autofluorescence. If that is what you were trying to ask. Thank you.
So the comment, Dr. Brijesh, I
Autofluorescence,
think
if
in
you see at the mechanism, it is because of excessive lipofuscin or absence of lipofuscin at the RPE. Here again, because it's a photoreceptor disease to begin with, and we are not talking of the RPE change. Probably we are looking at changes here. And the superficial changes are always better seen on um, infrared images or red free, and not the lipofuscin would be better seen, RP changes would be better seen on autofluorescence, is my thinking.
True. I mean, interesting. Thanks for bringing this out, Dr. Shrikanta. I know, like in IRDs, causative versus consecutive change, and again, consecutive versus causative change is always little complex to understand. So that's why the deep phenotyping is extremely important. So if there are no comments, can we move on to the next case?
Could I just make one more comment?
Please,
It may not be relevant, but do you find that the outer nuclear layer is thickened in these cases? Presumably because, not only do these patients have a preponderance of S cones, not only do they lack L and M cones, they have an abnormally high number of S cones. But is that your finding?
Tony didn't
Interesting,
check
Shrikanta.
exactly the thickness of the outer nuclear layer, but I will check all the cases and measure the ONL thickness if possible. Since these lesions are in the mid periphery or just above the arcade, so the OCT scan may not give the exact stand. So you need to take a standard value and compare with these. That's the challenge actually.
So
You could
have
use
you
a high
observed?
definition single scan that will give you a 16 mm scan. Probably if you position that along the arcade, you may be able to look at the I think we can all look into our cases and do that,
Yeah.
and look at and the disease somehow always starts in that annular layer around the arcades. So
Also, these variants are
and this
previously
is a
reported.
youngish patient, so probably it starts like this and then will throw up those pigments. Probably, as you said correctly, that could be a precursor where the cell death is seen. Apoptosis has happened, but not yet replaced by pigment.
But the shape is different, The shape was very different. It would be more like, sausage shaped, or what he said, oblong. as compared to the nummular pigment. So, if you overlay those pigments on this, I think the shape is different. I think we need to study more. I am not sure that these are precursors of pigment because this was too superficial. And we expect the pigment to come from the deeper layer up, right? So,
Torpedo-like lesions are also supposed to be comet-shaped, oblong kind of.
yeah, that is like, like they're not worm-like. So if you see here, this was oblong but worm-like, especially when we saw in the red free. Yeah, this one. See how they are? They are like, serpentine, almost.
Reminds you of
They're like
bees.
sausages, or maybe you can say boomerangs or something. You can keep all types of shapes, but I don't see them exactly like, I mean, the closest I would think would be like, something like a choroidal rupture or like an angioid streak, where the direction is different, but they are multiple. And especially here, in this particular patient, they were very dramatic and they are going all the way periphery. And they are not that many on the, I don't know, I think we have to see more. But it's very nice finding. We will, I think, pour over it a little more and then we'll try to learn more about it.
Sure. Thank you so much, everyone, for the comments. So next we can move on to the case 3 by Dr. Rubina Sheikh. So she'll be presenting on East or West, unraveling the best. Good to Dr. Rubina. Are you here? Rubina.
Hi, Rubina, can you hear us?
She's there. She just unmuted.
I'm trying to share.
Okay, we can hear you.
I did enter into full screen.
No, we cannot see your screen.
Yeah, just one. Are my slides now visible?
No.
Okay. Mhm.
Rubina, share the entire screen and not the window.
Yes, I have. Yes, Dr. Brijesh, I have clicked on enter into full screen. Is it now
So
visible?
no,
Not seen.
so
Rubina, just unshare first and then share the entire screen.
So team from Sai Numerative, could you please assist her? So there's some technical glitch.
Yeah, I'm also following it up, Doctor. Like,
Can I ask a question in between to Tony regarding
Yes,
the
please go
first
ahead.
presentation? Yeah. Hi, Tony. It's regarding the utility of multifocal ERG in cases where there is undetectable full field ERG. Like how often do you perform? Like, will it give extra information considering that there is significant amount of cone dysfunction which has already happened when we look at the full field ERG? Do I still do a multifocal ERG and get some useful information with respect to prognostication or to follow up the patient? Thank you.
Oh, good question. And I think it depends on the circumstances. But only yesterday, I saw a patient who had flat, undetectable, light adapted and dark adapted full field ERGs and a normal pattern ERG and a normal large field pattern ERG. So in that patient with severe photoreceptor dystrophy, retinitis pigmentosa, the preservation of the pattern ERG, and we could have performed a multifocal ERG, but here we tend to use pattern ERGs as a default because we're a bit quicker and they're less technically demanding. But in that case, we showed that macular function was preserved in the presence of quite severe photoreceptor dystrophy. And I think that's quite an important finding, and you can counsel the patient on that basis. And if you were to perform serial testing, you'd be able to establish stability as well. So I do think there's value in testing macular function, irrespective of the full field ERG changes.
So
Thank you.
I agree on that. And was your patient by any chance, was it EYS?
But maybe they'll go for whole genome sequencing, but I don't know.
Yeah, okay. Okay, fine. I have a patient with a couple of patients with EYS, the way you just described, undetectable photopic and scotopic, but the pattern and multifocal looks good.
And the patient also had a very large ring or annulus of hyperautofluorescence,
Yes,
but beyond the disc. So it was quite a large area, preserved central function.
similar. Yes, yes. In fact, the autofluorescence itself is indicative that I'm likely to get a, so normal pattern and this thing. Dr. Rubina,
I am
so
unable to share.
could you please log out and log in? You just try that. Maybe that works. Meanwhile, you can just
Yeah.
continue our discussion. Coming back to your question, and so looking at the YNL thickening in case of enhanced Escon syndrome, have you observed that? Because if you look at embryologically the way enhanced Escon syndrome manifests, do you think that's a possibility unless there is an apoptotic body getting deposited there? Professor Robson?
Sorry, I didn't catch
hear
that.
me?
Can you say it again, please?
Okay, please. So now I was just, you were asking, looking at the ONL thickening in enhanced Escon syndrome. Have you observed in your series? Because if you look at the embryology of how this happens, so do you think, is it because of the more number of cones, or is it because of the
Yeah.
apoptotic bodies getting deposited over there? What's your hypothesis? I mean, why did you ask
Yes,
that
yes.
question?
So,
Actually, I just want to know.
yeah. So I haven't
Yeah.
quantified this, but anecdotally, I just noticed that in many cases,
Yeah.
and I suspect it's simply related to an abnormally high number of cones,
Okay.
most of which express S-conopsin.
Okay. So I do agree. Okay, so fine. I think Shrikanta, you wanted to comment? I think I just written.
Yeah, so like
It's
what
written it,
Tony
yes.
told, we need to follow these patients longitudinally to look whether how they are progressing and all. So definitely there is some association or correlation of cone dominant linear skin, but you need to follow this patient for years to come to any conclusion.
Okay. Dr. Divansh, have you started sharing your screen? I mean, do
I
I
think
presume Rubina has mailed you
Dr.
the
Rubina
presentation?
did not.
He's sharing Rubina's presentation, I think.
Perfect. Very good. Please go ahead and share so that she can present.
Visible? Is my screen visible?
Yep.
Yes, it's visible. It's in full screen mode. Please go ahead.
Okay. So, good evening and sorry for the technical glitch. So, moving ahead to a very good, interesting topic of East or West, unraveling the best. The objectives of my today's presentation would be for a case-based discussion on Best dystrophy associated with CNVM to understand the various different phenotypes in Best dystrophy and the recent advances in Best dystrophy. So, Best dystrophy, as we know, is a mutation in BEST1 gene, which was first described by Frederick Best in 1905. It is one of the most common macular bestrophinopathy, and its incidence is around 1 in 10,000. The BEST1 mutation is also associated with other phenotypes like Best vitelliform macular dystrophy, adult onset vitelliform macular dystrophy, autosomal recessive bestinopathy, autosomal dominant vitreoretinochoroidopathy, RP associated BEST1, and MRCS syndrome, which has microcornea, cataract, rod cone dystrophy, and posterior staphyloma. With this, I come to the case wherein a 25-year-old male who was a resident of Karnataka presented with the chief complaint of decrease in vision in both the eyes along with metamorphopsia. The uncorrected visual acuity in right eye was 20/50, which did not improve on pinhole, and the left eye uncorrected visual acuity was 20/30, which did not improve on pinhole. So the anterior segment findings were unremarkable. However, as we can see, the left eye fundus photo showed the presence of multiple yellow deposits which are scattered all over the posterior pole, and few of them are above the arcades, along with foveal atrophy marked in red. And I would like to highlight temporal to the fovea, there appears to be a yellowish grayish like membrane, which is suspicious. Also, in the left eye fundus photo, along with the yellow multiple deposits which are seen on the posterior pole and foveal atrophy and inferior scarring, in this fundus photo, though it is not clear, temporal to the fovea, there was the presence of a heme, a speck of heme. So we went ahead and did a fundus autofluorescence. So this is the blue autofluorescence of the right eye, which shows numerous multiple punctate hyperautofluorescent spots which are scattered throughout the posterior pole, and they extend beyond the vascular arcades, which are suggestive of lipofuscin accumulation. There are central areas of irregular hypofluorescence, and it is also, I would like to highlight that there is a ring of hyperautofluorescence, which can be more clearly appreciated in the infrared autofluorescent image corresponding to our fundus photo of the suspicious area. Moving on to the left eye fundus autofluorescence, you can see a similar like picture on the left eye. Again, over here also in the surrounding the central hypoautofluorescent area in the macula, we can appreciate a ring of hyperautofluorescence, which is also clinically correlated in the infrared autofluorescent image. So coming to the OCT of the right eye, the internal retinal layers appear to be normal. However, in the outer retinal layer, there is the presence of a subretinal hyperreflective material, which is shown in the blue arrow, and there is a hyporeflective area suggested of a subretinal fluid. Going to the OCT angio, here we can appreciate the presence of a flow signal vascular network which is tangled, as well as dead tree appearance with a perilesional halo, and the corresponding FFA shows a presence of differential hyperfluorescence in the late phase. Moving on to the left eye OCT, this also shows the presence of the subretinal hyperreflective material along with a hyporeflective space suggestive of a SRF, and the left eye OCT angio shows the presence of a branched vascular network which is active. However, in the FFA, there is not much differential hyperfluorescence seen in the later phase. Moving on to the full field flash ERG of both the eye, it shows normal and photopic and scotopic responses. However, in the EOG of both the eyes, the square waves appear to be regular, but the light rise is absent. So the difference in the maximum and minimum in the both the eyes appear to be similar, and the Arden ratio is greatly decreased to the right eye to 1.08 and in the left eye 1.09. So this brings to the differential diagnosis of both eye Best dystrophy with CNVM, and the patient, due to socioeconomic conditions, was planned for intravitreal bevacizumab, and family screening and genetic counseling was advised. So the genetic report of the patient showed the presence of BEST1 gene and with a variant of C86828 greater than G, and it was mostly autosomal recessive. So differentiating between the three important forms, that is BEST dominant autosomal dominant Best macular vitiliform dystrophy, autosomal recessive bestrinopathy and adult onset vitelliform macular dystrophy is important, wherein we can, in autosomal dominant variant, you have the classic yellow-orange round subretinal lesion in the early finding, and it can lead to further atrophy and pigmentary changes. In the autosomal recessive ones, we have multifocal yellowish subretinal vitelliform deposits, which can be associated with macular edema, CNVM, or scarring. And in adult onset vitelliform macular dystrophy, there is bilateral symmetrical yellow round or oval shaped lesions, but these lesions are smaller when compared to Best disease. On OCT in autosomal dominant, we can there will be presence of subretinal fluid with hyperreflective material within the lesion, and subsequently there may be RPE atrophy with outer retinal thinning. In autosomal recessive also, we can see subretinal fluid with diffuse outer retinal changes, and the adult onset vitelliform macular dystrophy on OCT shows the location of yellow material under the sensory retina and above the retinal above the RP. The fundus autofluorescence in all of them show autofluorescent lesion with hypoautofluorescence in the areas of atrophy. The ERG in autosomal dominant and adult vitelliform onset vitelliform macular dystrophy is normal, but in autosomal recessive bestrinopathy may be abnormal or reduced. The EOG is normal in adult onset vitelliform macular dystrophy, and it is reduced in autosomal dominant and autosomal recessive bestrinopathy, and it is severely affected in autosomal recessive bestrinopathy. So our patient received 3 doses of intravitreal bevacizumab and post 3 doses of intravitreal bevacizumab in the right eye. The vision remains stable, that is 20/50, though the OCT did not, this is the pre-injection and post-injection OCT images, though they did not show any much improvement. However, in the OCT angio, we can see that the network is appearing like a dead tree kind of an appearance. So moving on to the left eye OCT image, the vision after 3 doses of intravitreal avastin still remained same, that is 20/30, and the OCT though did not show much changes. In the OCT angio, we see the dead tree appearance, which is suggestive that there is no active network currently. So we decided to observe the patient and visually rehabilitate the patient and convince the patient to undergo family screening. So on family pedigree, we saw that our patient was a first order, though it was, so we saw that even the sister had the similar kind of prodigy. So what is the pathogenesis of Best dystrophy? So in Best dystrophy, usually there is a mutation of BEST1 gene, which is seen on chromosome number 11, and there is defective bestrophin protein in the RPE, which leads to an abnormal iron transport, and it brings about an altered calcium signaling, which leads to a disruption or dysfunction in RPE, and there is accumulation of lipofuscin and waste material, which leads to the accumulation of a vitelliform material, and subsequently there is progressive RPE and photoreceptor damage, which leads to the later complications like CNVM, fibrosis, scarring, and progressive central vision loss. So the clinical features that we usually see in a Best macular vitelliform dystrophy are solitary, round, horizontal, orange to yellow, slightly elevated lesions which are located at the fovea, and the size ranges usually from few microns to few millimeters in diameter, and in the later stages there is atrophy and pigmentary changes. So the various stages of Best dystrophy is the first stage is the pre-vitiliform stage where the fundus in vision is normal. Only the EOG has early changes. So the EOG is abnormal. In the second stage, you have the classic egg yolk lesion, but the patient will have normal vision or mild vision loss. Stage 3 has a pseudo hypopion stage where there is the layering of lipofuscin occurs, and on stage 4 is the vitally eruptive stage where the breakup of these lipofuscin material occurs, giving an appearance of a scrambled egg kind. And in stage 5, atrophic, which is the atrophic stage, there is central RPE atrophy and retinal atrophy. And stage 6, CNVM occurs, which can be seen in approximately 20% of the patients. So how exactly does CNVM occur in Best dystrophy? So as I already said, that there is a mutation in BEST1 gene which brings about RPE dysfunction. This leads to chronic stress and degeneration, which brings about breaks and defects in the Brooks membrane, and there is an increase in VEGF and other angiogenic factors, and choroidal vessels ingrowth occur, and there is formation of CNVM. Most commonly, type 2 CNVM is seen. So the patient usually presents to us with a sudden decrease in vision, or he can have metamorphopsia or a development of new central scotoma. There can be presence of SRF or hemorrhage along with a grayish membrane. And amongst all the imaging tools, the OCTA is most important investigative modality, wherein you can see tangled neovascular networks can be appreciated. So these are usually treated with intravitreal anti-GF. PDT was used initially, but now it is rarely used. So when we on further follow-up, what are the signs which suggest regression in CNVM? So clinically, there would be an improvement in visualization. The patient will be less symptomatic in the form that the metamorphopsia would reduce, the central scotoma would reduce, there would be no fresh hemorrhage that would be seen on fundus clinically, and there will be pigmentation or scarring which will be formed, and there will be flattening of the previously elevated lesion. On OCT, there can be seen that the subretinal fluid can resolve, and the CNVM will become smaller and more compact, and a fibrotic scar can be appreciated. On OCT angio, we can see reduced vessel density, and there will be loss of the fine capillary loops, and mature networks would be formed. So regression would basically mean that it is either inactive or it is scarred. So in a recent the recent advances is that there was a most recent milestone which was achieved on and published in March 2026, wherein there was a gene therapy which was AAV based, that is adenosine associated virus based gene therapy was used to deliver a healthy copy of BEST1 gene into the RPE cell. It is in phase 1 of 2 of the BIRD-1 clinical trial, and it included patients of 2 cohorts, one which was having Best vitelliform macular dystrophy and autosomal recessive bestrophy, and they followed up and they observed that at 3 months it was well tolerated and there was no sign of ocular inflammation or any adverse effects were not noted. However, they also noted that there was functional improvement, as in there was a 12-letter gain in BCVA in treated eyes at the end of 1 month, and even the central subfoveal thickness decreased to 23% by 1 month. So the take-home message is think of autosomal recessive bestrophy when Best disease looks atypical or bilateral, and EOG is markedly abnormal. ERG may be normal or reduced, and genetic counseling helps to differentiate from autosomal dominant Best vitelliform macular dystrophy and helps in counseling. the patient. Thank you.
Thank you, Rubina. Coming back to the IRD part. So your patient had homozygous mutation, right?
Yes.
Okay, so fine. So on the ERG was normal.
Yes, doctor.
So what was the refraction? I presume was she hypermetropic
Yes,
or was
he was
normal?
hypermetropic. It
He
was
was
in the right eye
hypermetropic.
coming up to 2 plus 2.50, and in the left eye plus
Okay.
1.50.
Okay, perfect. So Professor Robson, your comment on the case? No, you need to unmute. You need to unmute.
Yeah.
Oh,
Yes,
thank you.
please,
That was
please.
a great review, and thank you so much. So I think, typically there's always exceptions, but in autosomal recessive bestrophinopathy, ERG abnormalities typically develop from adolescence, but as you mentioned, there is usually disproportionate, severe EOG reduction. And I think EOG is sort of went out of fashion for a while, but actually, Best disease, you don't always see textbook lesions unless you do large family surveys. And I think there's other dominant macular dystrophies that can be phenocopies or overlap with the fundus phenotype and Best disease, like some pattern dystrophies maybe. I think also what can be useful is examining the parents, of course, because if it's dominant disease, a parent will be affected. Even if the fundus looks normal, the EOG you'd anticipate would be abnormal. And in fact, that's how they actually came across how they first identified autosomal recessive bestrophinopathy when they realized the parents had no fundus changes in normal EOGs. But thank you for a very comprehensive and interesting review.
Fine.
Thank you.
So Professor Robson, in your cohort, have you come across any compound heterozygous variants or like in between dominant and the recessive?
Yes, I think we have some puzzling cases. Definitely, yes.
Yeah.
And I think it's complicated by the fact that specific changes, specific best one changes can sometimes result in an unusually preserved or relatively preserved EOG light rise. So there is some variability, I think. So
Yeah, so but one thing what I've seen consistently as compared to the dominant versus compound heterozygous was the actual recessive ones. So the EOG in dominant will not be flat. The light
no,
rise
it
will
can be.
be
I think
less.
it can be. I think
Yeah,
it can be, but it's more variable. So I think
variable.
generally
That's
it's
right.
between about 100 and 140% in dominant disease, generally
Yeah.
between about 100 and 110 or 115 in recessive disease.
Yes, true. But in recessive, we'll see almost like maybe because there's no functional protein that could be the reason for the more severe EOG abnormalities. So fine. So Dr. Shrikanta, you want to comment?
Yeah, I have two comments. If you can go back to the ERG slide. The ERG, if you see here, both the B wave in the dark adapted 3.0 and light adapted 3.0, it looks subnormal to me. The amplitude
Yeah,
is
it is
somewhere
abnormal.
around like 150 to 200. And one more thing in EOG, if you see that the EOG, both the cursors are in the light phase. Probably if you see the EOG here,
Yes, Shrikant. So we discussed this actually before she came out with the presentation, and thanks to Rivina for chipping in the last moment and the actual presenter could not. So we were discussing typically for EOG 8 to 12 minutes is the correct time for the dark trough to be looked at. And for the light phase, it's around 24, 26 minutes. So light one is correct, but still you can make out that there is no light rise. So
yeah.
despite whatever timings are there, I think it is quite conclusive for Best dystrophy. So, Poorna, this case actually comes from my earliest retinal dystrophy experiences, and I've changed quite a lot. And I was very happy to see that I wrote whatever I wrote at that point of time. But no, still till today, also I have difficulty in the OPD in saying whether CNVM is there or CNVM is not there. And Shrikant would remember one of the studies that we did on Best dystrophies. There's one particular finding, these spaces in the inner nuclear layer. So whenever you would see them, the case would turn out to be Best disease. Yet, despite that experience, following these up and deciding when to treat, when to stop treatment is a big challenge for me even today, and I look forward to answers from all the seniors over here, how they go about in managing best with CNVMs.
And even Dr. Bridges, if you see the OCT here, you can see these fine hyperreflective spaces just
No, they are there.
extramacula. Yeah.
Yeah, in one of the eyes, they were quite prominent. Yeah, I agree with you.
Yeah,
this-
yeah,
See,
you can
one
see.
thing in So one thing about the CNVM with like, I mean, of course, Parvin ma'am and Subhadra ma'am also can comment. They respond really well to anti-VEGF. Okay, so because this always behave like the myopic CNVM and all that, especially in children who present with 636 kind of vision, they improve remarkably, though the macula looks very bad. So if you inject and if you're not seeing the expected response, then most of the time there is no CNVM. You can decide on the first injection itself because the response to injection is extremely good. And most of the time they will have the classic features. There is no confusion on that one. I mean, you can go ahead. You need not do an angiography all the time. The OCT angio and the OCT itself should be enough. The tricky thing here is that children, they don't complain, because the other eye is normal and all that. So adults sometimes they may, if they are very observant. That is one thing what you have consistently observed. The excellent response to anti-VEGF. So Parveen ma'am and Subhadra ma'am, you have anything to add?
Yeah, I just wanted to say the youngest child that we had reported many years back was, I think, 5 or 6 years old, and we gave him injection under topical. He was very cooperative, and everything resolved. But now we've been following him all these years, and now he's turned 16, 17, 18, and he had a recurrence. And all these years he never had a recurrence. So I was like, is it puberty? What is happening? He was like, I was like, yes, the literature says they always do very well. And 2 injections and he was fine. But now at the pubertal age, he has suddenly had come back with a large recurrence, good amount of blood, responded very well to the next injection. But I'm just saying, as our experience of years collects, maybe we will learn something more. And yeah, and I always give Avastin actually in all these retinal dystrophies and all, because most of the retinal dystrophy patients, they respond to 1 or 2 injections. So I think Avastin is very good for them.
Yes, exactly. You should not, that's an important point. You should not, shift to like a higher fancy anti-VEGF. You should start from the basic ones because they respond well. You don't need, the other ones. Fine, ma'am, excellent. So
Even
are there
same
any
thing I
other
found
comments?
in CNVM with colobomas, because we do see. But
Yes.
surprisingly, a lot of these children which I have, like 5, 6 year olds, they actually complained of decreased vision. I don't know, they were playing some particular game where they were closing one eye or the other eye, or they're looking into some, video game or something. But I was surprised because I also never thought that they would complain of loss of vision, but actually they did. They noticed that
Yeah, definitely.
hemorrhagic scotoma in that eye.
Most of the time it will be a missed trivial trauma. Usually the Brooks membrane is very brittle in them, and then even with this thing so well playing, and that might giving rise to this kind of CNVMs. But always please, even if they're suspecting minor suspicion, please treat because the
Yes.
results are excellent. Even if you're wrong, that's okay, it
Mm.
doesn't matter. But if you miss a CNVM because the prognosis is usually good in these kind of cases. Fine. So any other comments from the Vice Council? I think Rajani ma'am has logged out. Parveen ma'am, I don't see her.
I think vision drop is the amount of vision loss is an important clue for CNVM in BEST. When we are unable to decide whether the fluid is due to CNVM or due to the BEST. And recently, in the last tone rounds, actually, this was the case discussion, BEST CNVM. And when the patients had CNVM in IRDs or BEST disease, the amount of vision drop was drastic, like 2200, 2400, 2150. And in your case, both the patients had 2050, 2040 vision. So maybe there is network, whether it is active or not, whether that is the one which is oozing the fluid or not.
Exactly. My queries
I
are these only, and I have started relying a lot on OCT angiography rather than even FFA or the other modalities. Because even FFA has so much back hyperflow, it becomes very difficult. OCT angio gives you that morphology of vessels and those whatever non vascular signs around it, which can give you clues. So Rubina did mention about a halo around one of the vessels. So I did use that actually to stop the treatment. But this was one of my first cases of retinal dystrophies. It was nice going back.
Definitely, it was nice. It was nice. Very like fine. I think one final comment from Dr. Shrikanta before we call it a day, because we are already overshot by 20 minutes. Then
Yeah,
what
I
Dr.
agree
Mudita
with
allotted.
Dr. Bridges that OCT angiography could be challenging. So recently I was going through a paper where they described best CNVM. They did this 3D reconstruction map to look for the CNVM or the elevation. Especially this is very, very helpful in cases where there is subretinal material which can be confused with CNVM. So 3D reconstruction map maybe in specific condition may help in this condition.
Perfect. Fine. Thank you. Thank you so much. Professor Robson, you wanted to come?
Yeah, just one comment. Another diagnostic clue, I don't think you mentioned it, is that in recessive cases, there's often association with closed angle glaucoma.
Yes.
Yes, she mentioned it. This patient was an hypermetrope, and she has been screened for it. Patient has already been screened. Because even in my most of these dystrophinopathy patients, they never lose vision because of dystrophy. They lose vision because of the glaucoma. So it's extremely important to get a gonio done, keep the glaucoma specialist in the loop, and make sure that they don't lose vision. And they're very refractory to do trap, whatever the thing and all that. So it's better to recognize them in the early phase.
They get malignant glaucoma. With that angle closure, then they go into malignant glaucoma.
Yes. Otherwise, even in recessive cases, the prognosis is right. I mean, they don't do that well as compared to dominant, but decent enough, ambulatory. They can be independent. So that much of vision they are likely to retain. Fine. So thank you so much. Thanks once again, Professor Robson, for taking our time and agreeing to be part of this.
No, my pleasure. Thank you for inviting me.
Thank you. Thank you so much. And I would like to thank once again the Subhadra ma'am, Rajini ma'am, and Parveen ma'am to be part of this webinar, and also all the presenters. Excellent presentation. I'm really happy to see the quality of IRD presentations are going very high. I mean, to come from this part of the world, it's really, I mean, the way it used to be, even Subhadra ma'am, they really struggled, during the earliest to raise awareness about these things. And today we see fellows presenting and describing genetic reports. Fellow extremely, I mean, I was very happy, very, very happy. It's a very good development. And I would like to thank President Vishali Gupta ma'am and the Vice President Karobi Lahiri ma'am and the entire team of VRSI, especially Dr. Modi Tyagi, the Chairman Scientific Committee of VRSI, and not to forget the Sai Numerotech and team for all the technical support. And thank you so much. Thank you once again. Would like to host similar, IRD based grand rounds, maybe sometime sooner or later. We'll see. Fine. Thank you, everyone. Bye. Good night.
Good night.
Good night.
Good night. Thank you. Lovely, lovely.
Good night.
Thank you. Thank you.